Good morning, everyone, and thank you for joining us this morning for Winship Grand Rounds. If you're Emory University or a healthcare employee and would like to receive CME credit for the hour attending today, the login information can be found in the chat feature at the bottom of your screen. If you have any issues with this webinar or CME login, please send Julie Hawkins an email or a note in the chat feature and we can help you. This morning, we are so pleased to welcome Dr. Kim Margalin. She is waking up at 4:30 in the morning, her time, to be with us today, and we're super appreciative. She's the medical director of the melanoma program at St. John's Cancer Institute. She completed her doctorate at Stanford University and her residency at Yale New Haven Hospital. She specializes in melanoma and other skin cancers with a focus on immunotherapy. She came to St. John's from the City of Hope, where she worked for over 30 years, stopping out for 6 years at the University of Washington and a year at Stanford. Dr. Margolin has co-led the Cytokine Working Group and the Cancer Immunotherapy Trials Network. She's been an active participant in the SWOG Melanoma Committee and has served on ASCO committees as well as the Society of Immunotherapy for Cancer. She also has served on FDA's Oncology Drug Advisory Committee and has been on 2 advisory committees for the European Organization of Research and Treatment of Cancer. She has a strong interest in brain metastases and melanoma and using systemic therapies to treat these. We are just so thrilled to have her today. Personally, I think she was one of the few females in melanoma when I was a fellow, and I really have looked up to you so much throughout my career. So I'm really excited to have you here today, and welcome.
Thank you so much, Raggi. I am delighted to be here, although sitting in my kitchen isn't quite as exciting as it would be to go to Atlanta. So I titled this talk "When Melanoma Metastasizes to the Brain," and I put the yesterday in parentheses because I really don't plan to talk about the really bad old days when we had almost nothing for patients with melanoma metastatic to the brain. I'll talk mostly about some biology and results of clinical trials, and maybe a little bit of speculation about where we're going. I will warn people that if anybody was at, I guess it was a melanoma symposium a year and a half ago in March of 20, before you know what hit the fan, you may recognize some of the topics and some of the slides, because I was fortunate enough to be invited to give a talk for that symposium, which was actually quite nice for me as well, because there were some great talks there. And I couldn't provide you with all new slides in this relatively short period of time, but I did my best to update the slides. And this is just to show you what happened when I moved from Duarte to Santa Monica. I switched directions, if you can recognize the map of Los Angeles, from a 23-mile straight freeway all the time commute that really did last 25 minutes, to a sort of a crooked commute towards the beach in the opposite direction, which according to the Google Maps at some ungodly hour of the night was supposed to be a 25-minute drive, is now turned into almost an hour. So definitely gave up a little on that end, but I'm having a good time. My disclosures. And so here's just some facts and figures about melanoma when it metastasizes to the brain. And I'll just say I kind of object to the term melanoma brain metastases because it makes it sound like something in the pathologist's tray rather than what patients suffer, which is advanced melanoma with metastases in the brain. So I tend to be very careful about how I use the term. As you may or may not know, melanoma has the highest case rate of brain metastases among all of the solid tumors, the other 2 being lung cancer and breast cancer. Because those 2 diseases are far more common, the overall incidence of brain metastases among solid tumors of adults is among lung and breast cancer patients, but nevertheless, for us melanoma doctors, or melanomaniacs as I call us, the incidence among our patients, or the percentage, is still very high, up to half over the course of their disease if they have metastatic melanoma, and even in the old autopsy series, higher up to about 3/4 of patients. It's also a not unusual site of treatment failure among patients who may be in remission of their advanced melanoma, especially now that we have drugs that provide remissions in a large fraction of those patients. There are also sort of rare variations where you might want to speculate that there's immune control of the disease in other parts of the body, but some kind of an escape in the brain, including as the sole site of metastatic disease after the primary and possibly metastases. Well, no metastases in the case of this bullet, the sole site of metastatic disease. Brain metastases can occur late, either with other advanced lesions or by itself. And rarely a patient will present with brain metastases without a known primary of melanoma. And in that case, you're often biopsying the brain in order to find out what is the histology. Historically, as I said, the bad old days, the median survival was only 4 months, and all we really had was surgery, which is really not possible for multiple metastases, or whole brain radiation, which really does almost nothing for these patients. And we had chemotherapies of a cytotoxic nature, not the targeted ones we now have, that even in the case of those that penetrated into the brain, such as temozolomide, were not very active. And so the response rate in the brain was well under 10%. And this is what the survival curve used to look like when I started in this field. In the basic pathogenesis of melanoma metastatic to the brain, some of the features of metastases in general include local invasion, the epithelial mesenchymal transition, which is a whole set of transcriptional patterns that confer certain pathways on the melanoma and cause it to behave in certain ways vis-a-vis the immune system, which is probably the main control of what happens in the brain. The motility, remodeling of the extracellular matrix, and the interaction with stromal cells as well as new cells. When looking at the features of brain metastasis specifically, it's known that these tumor cells arrest by their size at branch points in the capillaries. They attach to endothelial cells and they extravasate and migrate across the blood-brain barrier with a disruption of tight junctions and degradations of these proteins involved with the extracellular matrix, and then they see the brain parenchyma. So some of the questions that are yet to be answered, but are the topic of major research, include whether melanoma over other tumor types has an enhanced ability to cross an intact blood-brain barrier, or to break down the blood-brain barrier to its advantage with these various enzymes and motility features. Is melanoma particularly adept at the vascular co-option that allows it to, snuggle up to the endothelial cells, get through, and sometimes even feature histologic changes that make it look like it has its own unique vessels? Does melanoma have an increase in its interaction with astrocytes, which is a very important aspect of its ability to survive and grow in the brain? And we'll touch on that very briefly later. Can melanoma induce a more immunoresistant microenvironment, or is that microenvironment sort of programmed into the brain? If the former, are the mechanisms intrinsic? Was the melanoma born with those mechanisms, or are they adaptive? Did the melanoma acquire them as it changed through its course through the body? And most important to those of us who are clinically oriented, are those mechanisms therapeutically targetable? I mean, I'll tell you the punchline as yet. I guess the answer is maybe. There are some lines of investigation that involve the use of drugs that are that inhibit vasculogenesis, let's say, and they are being used to target brain metastases. So in terms of the immunopathogenesis, we actually talked about this, and I think I might have repeated this slide in part in the second set of bullets. These cellular interactions between melanoma cells and neuronal cells include, very importantly, this phenomenon of astrogliosis, or an injury response to such things as strokes or a surgeon cutting on the brain, and the neurotrophins that support the brain recovery may also support the growth of tumor. Microglia are like the macrophages of the brain, and they mediate some aspects of the immune response, but mostly are responsible for resistance. And then this very important phenomenon that in many melanomas metastatic to the brain, the tumors have a loss of function of PTEN, which is an important negative signaling pathway upstream from a whole lot of positive signaling pathways, including AKT. And usually this is an epigenetic phenomenon rather than a deletion mutation. But when it happens, you get upregulation of the downstream mediators because, as I said, PTEN is a negative signaling. And then you get activation of the mTOR pathway, which is an important pathway for cell proliferation and growth and metabolic fitness. And so when that happens, the melanomas are more robust in the brain. And then, of course, there's a lot of immunology about the about the melanomas in the brain, which are not controlled very well by the immune system. It's sort of an immune desert, as we say, with a lot of cells that promote tumor and very few cells that attack tumor. And I won't be talking too much more about the immunobiology of brain metastases, or else we would never finish, and you guys would be sleeping even at the late hour of 7:30. Just a few pictures of what the brain looks like in around the metastases. And this is obviously taken from a review paper, but just to show you, if you imagine or if you know something about melanoma metastatic to other sites, it in many ways, if you look at the elements in particular, you see that that the surrounding microenvironment is really not that different from the surrounding microenvironment in other sites of metastatic melanoma. For example, I'm trying to figure out a way to, I'm just going to collapse this for now. There's the basic tumor cell and T cells. Actually, this is a dendritic cell. It's a lot of interactions with T cells through this immune synapse. And these are CD4 cells, and these are CD8 cells, and they cooperate with each other surrounding the dendritic cell. Here's the tumor cell with a very empty version of its immune synapse, which normally has, about 100 different molecules. When it interacts with these tumor-associated macrophages and with the myeloid-derived suppressor cells, both of which are among the cell subsets that sort of promote tumor and do not promote immune control. And as you can see, there are some of these soluble molecules, such as the decrease in tryptophan resulting from arginase and resulting in kynurenine, which is sort of a poison to T cells. And then you have some of these suppressive cytokines like IL-10 and TGF-beta, and some of these small molecules like nitric oxide that are also sort of produced by in sites of inflammation, but they're not good for the function of T cells. Sorry. This is one of my favorite topics. I'm only dedicating one slide to it right now, but Priscilla Brastianos and her colleague Scott Carter at the Broad Institute have made a career over the last half decade or so in studying the term called branched evolution in solid tumors metastatic to the brain. And they've looked at a whole lot of different tumor types and demonstrated that something in melanoma and other tumors that was first shown in renal cancer, which is that the primary tumor usually features what's called a truncal mutation, which is present in every clone of the cells that give rise to the tumor. So in this case, it happens to handily be the one so far targetable mutation that drives tumors from before they're born, because many benign moles also feature the mutation of BRAF at the 600 amino acid site that gives rise to an enhanced signaling through the BRAF pathway and the malignant phenotype. But what happens as these tumors then mutate further or acquire new changes in their genome, they will go to, let's say, the liver, and all the clones that are in the liver will carry another new mutation, and the ones that go to the lung will have another new mutation, all the same as each other, but different than the ones in the liver. And so here, this is a biopsies of the brain, or autopsy series of the brain, where you've got relapse 1, relapse 2, relapse 3, recurrent. And these brain metastases will all have the same set of mutations, including the truncal mutation and including whatever mutation of the organ that was right before it metastasized to the brain. So let's say it was in the lung first, then it'll carry the lung metastasis signature and its own brain metastasis signature. And they have, of course, gone through the sequencing and found that for any number of other tumor types, there will be possibly new actionable mutations that can be used therapeutically to treat the disease when it's metastasized here. And there's a large, I call a match type of study, like the NCI match, in which patients' tumors are sequenced, and then the drugs that may be active for those mutations are used to treat the patients. Of course, we don't know the results of that study yet, but we will. Some of the clinical factors and driver mutations that have been associated with brain metastases don't do a lot to help us know really with certainty whether the patient's going to develop brain metastases and how they're going to behave. But some of the features that are generic to melanoma metastatic disease in general, and not just the brain, include the tumor burden and the organs to which it's metastasized, and the serum LDH. Just some other sort of bonus points. Uveal melanoma, despite the fact that it arises in the eye, which is awfully close to the brain, and despite the fact that it can be pretty vicious when it does metastasize, is almost exclusively spreading to the liver, and that's got a whole different biology, and some people whose careers were based on the spread of uveal melanoma to the liver, but almost really quite rarely to the brain. Now, it may be that those patients, if they live long enough, they would eventually develop brain metastases, but based on the natural biology of the disease right now, it doesn't seem that way. The driver mutations that we have drugs for that are featured in a high fraction of melanomas are slightly more frequently associated with metastasis to the brain, but not to the point where we would, look at our patients and sequence their tumors and say, oh, that one's going to have brain metastases and that one's not. It's not that straightforward. Some of the, well, I already mentioned these things at the bottom of the slide. This is a series that was published in a dermatology journal that just looked at, I don't remember exactly how many patients, but looked at some of the prognostic features that were associated with 213 patients. The prognostic, sorry, not 213, 2132 patients whose sites of metastatic disease in the brain were correlated with the sites of their primary, and the p-values, of course, to look at are the ones with the yellow background. So male sex has a somewhat higher hazard ratio for brain, about a third. Desmoplastic melanoma, which is often found on the scalp of men who are follicularly challenged and who are older, also has a statistically significant hazard ratio of actually the highest on this particular chart of 2.27 for metastasis to the brain. And then the others are actually lower. So those hazard ratios are below 1. And again, with a significant p-value. For what it's worth, I mean, again, these are not sufficiently strongly associated as to help us really treat these patients or survey these patients in a way that's specific to the possibility of brain metastases. This is interesting, though. Ulceration is a really bad prognostic factor in the primary for melanoma in general, although the hazard ratio to the brain is only 1.49, but it's associated, at upstages primary melanomas, and it's said to be associated with a higher propensity to travel hematogenously, as though the fact of ulceration is associated with a biological behavior that is more aggressive and a worse actor. So this is some of the results of one of my favorite papers, which is from Grant Fisher working with Mike Davis's group at MD Anderson. And what they did was this very exhaustive, you'll see the main slide, actually I'll show you now. Where did it go? Oh, you know what? Somehow the main slide got dropped out. So the main slide shows you a person and shows you the different assays that were done on tumors, something like 50 tumors from, now I can't remember the number of patients, or maybe there were more tumors, 70 tumors in 50 patients, something like that. And what they did was they looked at the whole exome sequencing, they looked at gene expression based on RNA sequencing, they looked at proteomics, and these were all patients who had brain metastases, and they showed that the genes that were associated with the immune infiltrates around these tumors in the brain were also associated with survival. So even if you're not a melanoma doc, this seems to be true for a lot of different tumors. If you have immune infiltrates, particularly CD8 cells around your tumor, and PS, not a lot of neutrophils or myeloid-derived suppressor cells or type 2 tumor-associated macrophages, you will most likely have a higher survival than those whose metastases do not look like that. So it's what we call the immune inflamed phenotype versus the immune desert or immune excluded phenotype. And of course, there's a genotype that's or a gene expression profile associated with that. And you can either look at it as a cluster with higher immune phenotype, or you can look a genotype rather. You can look at it as immunoscore, which is a sort of a collaboration of different cells in the tumor. You can look at it as a high and low T cells. You can look at it as a high and low B cell lineage, or you can look at it. The trick question here is a lot of neutrophils are actually a worse outcome, and low neutrophils is a better outcome. So the rest of these, are correlated with the higher, but this is flipped. The most favorable patient survivals were also associated with an immune, sorry, I just said immune gene expression, but also with glycolysis over oxidative phosphorylation among the infiltrating cells. So you saw in the previous slide, the immune score, cell subsets that I already mentioned, the opposite behavior for neutrophils, and then the spontaneous and cell line models of this really tour de force paper, which is in Cancer Discovery about 3 years ago, also showed that inhibition of OXPHOS, for which there are some investigational agents, was therapeutically effective in a mouse model, and they're currently doing a study of a different agent in the inhibition of oxidative phosphorylation to treat patients. So I had the fortune of reviewing this paper, and so when you review a paper, you're asked if you are willing to write an editorial, and I said yes. And so guess what? No good deed goes unpunished, and I asked my friend and buddy Colt Eggleston, who was a postdoc junior investigator at City of Hope at the time. So we wrote this editorial together, i.e. Colt wrote it and I fixed the grammar. But this is sort of a continuum from extracranial metastatic disease to intracranial metastatic disease. I didn't mention that for all of these patients, there were extra and intracranial metastases that were compared with each other. And that was what was unique about this study, because there's been plenty of other studies about brain metastases only, although I wouldn't say any of them was as elegant as this one. So as you go from extracranial to intracranial metastases, you get a decrease in the T cell infiltrate, a decrease in dendritic cells, and a decrease in macrophages. Now, macrophages can be good and bad. I would say for the most part, they're considered in the type 2 arena, which means they're not favorable to the control of tumor. Mitochondrial inhibitors are the ones that can inhibit this OXPHOS, and as you move towards metastatic disease, there's a response to targeted therapies, which I'll also mention very fleetingly later on in the talk. And of course, what I'll talk about is what I'm most proud of, the studies that showed the response to immune checkpoint blockade, which was very exciting because of the fact that these are large antibody molecules, and we didn't necessarily have any reason to believe that they would get into the brain themselves, and they probably don't, but the T cells do. So I've given away the punchline. So what about the management of patients with melanoma metastatic to the brain? This is, we're quickly becoming clinical, and the whole, I said at the very onset that whole brain radiotherapy is ineffective. It's almost completely useless. It gives the patients a little time to get their affairs in order and almost nothing else. What has become the standard, I would say, in the 90s, 2000s, and now, of course, we're in the next decade, is that stereotactic radiosurgery or stereotactic radiotherapy is standard and often used to treat as many as 7 or 8 lesions at a crack. And sometimes the radiation oncologists that will go back and do more SRS when there's another crop of brain metastases occurring in some of the patients who are less fortunate. Durable control is achieved with SRS, and the problem then becomes when patients develop changes in a lesion that's been irradiated. You have to decide whether there is tumor growing back, which is actually very rare. As I say, it achieves durable control, or whether those changes are a sign of radionecrosis, which doesn't always require surgical treatment, but sometimes does, sometimes requires steroids to quiet down the inflammation, may be symptomatic or may not. So it's kind of tricky to diagnose that and treat it. Resection is indicated for somewhat limited purposes, which include the diagnosis. Sometimes it's just not certain. Oligometastatic disease in the setting of everything else being controlled except the brain, sometimes it's appropriate to remove one, usually just 1 or 2 brain metastases. And then, of course, when emergencies such as hemorrhage in the brain or mass effect with reversible, with what's thought to be a reversible neurologic defect or threats to the respiratory center from herniation in the setting of a patient for whom other sites of disease are controlled adequately. If that's not the case, then sometimes that's what the patient succumbs to. But it will be remembered that patients with brain metastases now don't always succumb, whose brain mets are not controlled and who have extracranial disease don't always die as a direct result of brain metastases. They sometimes die from their extracranial disease. So aggressive management of brain metastases is indicated and is often done. Stereotactic radiosurgery is very active. It risks radionecrosis, and it does leave untreated the micrometastases. So that's why switching from ineffective therapy to therapy that is highly effective needs to still be considered for close surveillance. Systemic therapy, as I say, has been poorly active, poorly penetrant, except for temozolomide, and really only used when patients or their families are absolutely insisting on some treatment and have exhausted the other kinds of treatment, which is, for the most part, cancer immunotherapy. Just a couple of points. Circulating effector cells do get into the brain. Then this Engelhardt et al. Wrote a paper in 2012 that was called Capture, Cross, Crawl as a way to delineate and describe what was happening with T cells. And I think T cells are somewhat plastic and they can bend and get through. And there's probably some active metabolic processes that are also occurring when T cells get into the brain. But that's really what we think is happening when we treat with immunotherapy, and that leads to remissions in the brain, is that the T cells are activated outside the brain, but then they crawl into the brain, crossing the blood-brain barrier. And in fact, we know that they can cross back and forth. Some of those data come from my friends at City of Hope, who've worked on CAR T cells, the kinds that have a transgenic T cell receptor that looks like an antibody. Those cells, when applied inside the ventricles of the brain, can actually be found in the circulation. The activity of ipilimumab, which was the very first immune checkpoint blocking antibody that was studied and approved for treating metastatic melanoma and hardly any other tumors now, was comparable to its extracranial activity. Now, the response rate to ipilimumab, if you look through the old papers, is only between 15 and maybe 18%, but there's an additional maybe 10% or 12% of patients who have a durable period of stability, which may be an active immune response rather than just a natural history of the disease. And those patients appear to benefit as well. So we sort of consider the clinical benefit rate closer to around 30% among patients treated with single agent ipilimumab. So we did, in the cytokine work group, we did a study with 51 patients, and there was a simultaneous study being done with smaller numbers by Anna Maria Di Giacomo in Siena, and this showed this similarity of activity of ipilimumab in the brain to its activity extracranially. And so that was supposed to be a cute little animation when cancer immunotherapy took off in about 2011, and ipilimumab was approved in that year. And so was the first of the targeted agents, which was vemurafenib, but as a single agent, it didn't prove to be effective enough. But in combined therapy with a MEK inhibitor, it seems to be very active, even in brain metastases. I'll show you that a little bit later. So I wanted to show you the survival curve for the patients treated with ipilimumab, and as you can see, it's on a plateau of 26%, which pretty much mirrors what I was just saying about the extra clinical benefit rate. And I'm showing you here a pooled result from Dirk Schoddendorf, and these were the pooled data in general, not with brain metastases, for ipilimumab, where the curves change in slope changes at about 3 years for ipilimumab, and after that it's almost a complete plateau. And this was some of the work. This really reflects back to the work of Jim Allison, who, as you know, won the Nobel Prize 3 years ago for his work in the biology and the clinical work that came out of it of immune checkpoint blocking molecules. So just to show you some of the work of others, Harriet Kluger and Lucia Gilovano at Yale did a study of pembrolizumab, which was one of the several PD-1 blocking molecules that was approved about 4 years later, at the end of 2014, beginning of 15 for melanoma, a number of other diseases. And the objective response rate in this case did not mirror the objective response rate in the body, which is closer to 40% for melanoma. It was only in the 22 to 25% range for melanoma metastatic to the brain. What's behind that biology is not clear, because investigators moved on pretty quickly to look at combined therapy with ipilimumab and nivolumab. So this is to remind those of you who remember, or who don't remember but are interested in melanoma, the famous 067 study in which the combination of ipilimumab and nivolumab was compared with ipilimumab as a single agent. In this study, apparently it wasn't intended to be a comparison with nivolumab, at least in terms of how the statistical analysis plan was written, but it was not possible to avoid the temptation of also comparing with nivolumab. So this progression-free survival curves are shown here, which was what was reported first, and the first few times, and then survival came later. But here's the plateau. This is, remember, patients without brain metastases. So a plateau of around, what does that say, around 37% for long-term progression-free survival, and the overall survival plateau is significantly higher than that, because many of the patients are alive, but they're in relapse, and that's what that means. Somewhat lower, but that's what we've been seeing with single-agent nivolumab or pembrolizumab or any of the PD-1 and PD-L1 inhibitors for melanoma. Again, progression-free, so the survival is a little bit higher. And then this is the effect of ipilimumab in progression-free survival. As I told you, showed you the 25% plateau for overall survival is better. And this is from the study that we did as a follow-on in the cytokine working group using ipilimumab and nivolumab at their full doses. And as you can see, there are what we reported separately: the global, the intracranial, and then the the extracranial, intracranial, and the global responses. And these curves differ by something like 1 or 2 patients. And so again, pointing out that the intracranial response rate really mirrored the extracranial response rates. Now, the reason that I put these two curves together on the same slide, and we know it's illegal to compare across studies, is that I wanted to point out my caveat, which is that these curves look better. And why would that be the case with patients who had brain metastases? And I will tell you that it's patient selection. It's always been patient selection. In the old days, when some of us old people were looking at phase 2 studies for melanoma in the cooperative groups and in other settings, and we just got these lousy outcomes, but some of the outcomes were less lousy than others, and it was all about patient selection. And so the point I'm trying to make here is that in this study, many of the patients were found to have brain metastases as a result of their staging scans. And in fact, this was asymptomatic patients in the brain. So by definition, they were not known to have brain metastases until they were staged and they had them. But many of those patients had very, very small brain metastases and no edema because they were not allowed to require steroids either. And so this is just in my opinion, this is just what happens when you compare patients who have better performance status and smaller volumes of disease with those who do not. So the name of that study that I just showed you the results of was Checkmate 209-204 with 101 asymptomatic patients, standard doses of therapy, and the toxicity was no different than it is with patients without brain metastases. And the overall response rate was 55% globally. The durability looks promising according to that plateau. And I'm going to flip quickly through some slides for what happens with patients on the same regimen who are slightly steroid dependent. There was a limit. We tested a small cohort of 18 patients, or they had symptoms. And this was the way this was the asymptomatic patients, and this was the symptomatic patients in this study. This is just some of the demographics. About half of the patients, for those who were tested, some of the patients had never been tested, had the BRAF mutation, and some had NRAS, or one had NRAS. PD-L1 expression, which in melanoma, unlike many of the other diseases, isn't proving to be as important. And then again, a very small number of lesions in many of the patients. So here are the responses that I told you about in the asymptomatic patient. And here's the number: 58%, 54% by a blinded independent committee of investigators. So this is the symptomatic patients, only 18 patients, investigator measurements in the BICR committee. So for complete responses, they were the same. For partial responses, they found one, and progressive disease. So we were pretty close. The independent committee looked at 4 patients and 4 responses, and we found only 3. I can't remember. There was some trick for how we looked at the responses, but the point is it's very low. And so again, these are the intracranial progression-free, and the overall survival. It should mimic that exact same curve that I just showed you a few slides ago with the plateau, survival plateau in this range. Don't pay attention to the end of the Kaplan-Meier curve, of course. And response to treatment among the symptomatic patients was 4 of 18. So it was 22% in the brain, and the same everywhere. And this just is the little vignette about each responder. And interestingly, one of the 2 complete responders was on steroid at baseline. The progression-free survival of the symptomatic patients, of course, was much less favorable. Again, the 3 curves differ by something like 1 patient in this small cohort. Overall survival for the symptomatic patients was poor. At 40% on this short plateau. It sounds maybe a little better than you might think, but the median follow-up was shorter because we accrued these patients later on in the study after the other ones were partly overlapping, but mostly not. So in summary, the final 3-year results support the continued use of standard dose nivo and ipilimumab for neural melanoma and untreated brain metastases. Symptomatic patients can occasionally, but not often, achieve durable benefit. The concordance rates between investigator and independent review were very, very high, and the toxicity profile was not unique for patients with brain metastases. Similar results have been reported from smaller phase 2 studies, particularly at the Melanoma Institute of Australia. I'm sorry, I was merging slide sets. I put that in twice. Very briefly on targeted therapy for melanoma patients with brain metastases, you can see substantial activity against brain metastases using vemurafenib or dabrafenib in combination with their their partner MEK inhibitors. So that was what the Combi MB, which is combination melanoma brain. And this was also written by Mike Davis at MD Anderson, and looked at untreated and treated cohorts who were on, and there were allowed to be on steroid. So the objective response in the brain was in really the same exact range, and the control of intracranial disease, which is anybody who's below the waterfall curve here, was 78%. However, which goes along with the very high response rate of these combinations, but the duration of the response is only about half of the duration of responses to targeted therapy among patients without brain metastases, who are only being treated for their extracranial disease. And so it's hardly better than the data for the single agent BRAF inhibitor, vemurafenib, or dabrafenib, or now encorafenib. And of course, unfortunately, this is a progression-free survival, but the overall survival is not going to look much better. Some of these patients were, attempts were made to salvage, I hate that word, I'm sorry, to treat in second line some of these patients with immunotherapy, but immunotherapy following failure of targeted agents is actually remarkably poor. The unique features of brain metastases of melanoma that support the use of initial systemic therapy then are the frequent presentation of the asymptomatic brain metastases at the first staging. So the patients haven't had prior therapy in many cases. The small asymptomatic nature of the brain metastases and the lack of a requirement for steroids when you pick them up small and asymptomatic on staging. The high response rates to systemic therapies, where it's almost the same, but it is the same for immunotherapy, but not for therapy. And of course, rapid developments in both molecular biology and immunobiology that support novel investigations of this nature with different modes of delivery, imaging that's being investigated, and new mechanisms of action. These are retrospective studies of the sequencing of stereotactic radiotherapy and immune checkpoint blockade. And I want to just point out that most of these studies are getting, they're growing whiskers. And so most of which I looked at, most of the things I looked at, again, just to update for this talk, but really it's all retrospective data. And I think the bottom line from these data is that if you treat patients with stereotactic radiotherapy and then later give them immunotherapy, they do a little better than if you treat them with immunotherapy and then follow that with stereotactic radiotherapy. And the Margolin reason for that is sort of a duh, which is that because these are retrospective studies, these were patients who were healthy enough to give systemic therapy for because their brain mets, they either didn't have them or they didn't have them bad. And the radiation was given only because they had escaped metastases in the brain, and that's why they did less well. So it's not going to be until we have results from randomized and prospective studies that we'll know if my theory is correct. From the radiation oncologist's lens, stereotactic radiotherapy is associated with failure in only 12%, which is concordant with what I told you earlier about the extremely high long-term control rate in lesions that are radiated. SRS plus immunotherapy, however, has a 60% control rate, long-term control rate. And when you give SRS plus targeted therapy, it's just about as bad as either one alone for long-term control. And of course, the missing element is in this, even in retrospective studies, is the data for systemic therapy alone, because that hasn't been around for that long. Whoops. So radionecrosis is the problem that I mentioned to you earlier, and this is just some papers. I'm happy to, I guess this is being recorded, so you got the references here. Again, I don't know for sure what the biology is behind radionecrosis, but my theory is that these are our patients who are doing well. They're doing well longer. It may be that they're responders and they have an influx of immune and inflammatory cells that are giving rise to this radionecrosis effect. I'm going to skip this slide and just move on to the end, because I'm supposed to leave some time for Q&A. Some of the ongoing systemic therapy trials that will address some of the remaining unanswered questions are listed on this slide, along with the studies that are along with the study questions that are being addressed. And I'll just mention now that the FDA has held sort of think tanks to bring together people who are expert and people who are interested in brain metastases, which range, when you go to a brain metastases summit of any sort or an experts conference, you have quite an assortment of types of doc, which ranges from radiologists, radiation oncologists, neurosurgeons, neuro-oncologists, medical oncologists, social workers, and palliative care people. So it really opens up one's world to meet all these people and hear about their interesting ideas and exchanges of information. So Harriet Kluger at Yale has followed her work on pembrolizumab alone with the pembrolizumab plus Bev. This arose initially from the use of bevacizumab to treat radionecrosis, but also the concept that melanoma, wasn't recognized in the old days to be one of those tumors that you could treat successfully with inhibitors of vascular endothelial growth factor. But it turns out that there are some instances where there may be responses, or it may synergize with the immune checkpoint blocking agents, in particular bevacizumab or blockade of vascular endothelial growth factor has beneficial effects on the dendritic cell maturation, or the maturation block that occurs when dendritic cells are exposed to VEGF. And so it may be that that's a way to spark the immune system. Lenvatinib is one of the dirty kinase inhibitors that has many targets and is also being used particularly by the company that makes pembrolizumab for studies with the goal being to find drugs that you can combine with PD-1 blockade that aren't as toxic as the currently available CTLA-4 inhibitor. Georgina Long and her many colleagues at the Melanoma Institute of Australia started a few years ago a trial called ABCX, because ABC was the Australia Brain Consortium or something like that, and then X is for X-ray, trial that randomized patients to immunotherapy alone, same drugs, Nivo and Ipi, with or without stereotactic radiotherapy as a planned, initial treatment. So that's ongoing. I don't know how far along they are with their accrual. Hussein Taubi, who was my partner in crime for the Ipi plus Nivo trial, who's also at MD Anderson, did a study of asymptomatic patients where Bev was combined with atezolizumab. No surprise that Bev and atezo are made by the same company, and also are doing a pilot study of Encobini with nivolumab for BRAF-mu. I think this was completed. Bella Glitza, also at MD Anderson, was doing this is another favorite regimen, Pembro plus low-dose Ipi. And Bella is very interested also in the treatment of leptomeningeal disease, to the point where she's injected nivolumab into the CSF by lumbar puncture. I haven't seen results yet, only safety results that she presented at, I think, this last ASCO, and it looked like you could do it. Zainab Arolu at Moffitt and on behalf of SWOG has has written and initiated the trial of Encobini plus Nivo versus Ipi plus Nivo for the half of patients who have BRAF mutated melanoma. And as you folks at Emory very much know, what we'll call the president's regimen of pembrolizumab plus stereotactic radiotherapy or radiosurgery is another one that has been studied, as has nivolumab plus SRT by Mike Lim, who's a neurosurgeon who translocated from Hopkins to Stanford in the past year, and Dirk Schadendorf at Schadendorf is in, I can't remember where in Germany, suddenly Essen? I can't remember, sequencing of cobimetinib and vemurafenib, which is again the pair of MAP kinase inhibitors that is produced by the same company that brings us atezolizumab. And this is a sequence for those who are interested in understanding how MAP kinase inhibitors sequenced before immune checkpoint inhibitors without waiting for progressive disease, but in a planned fashion, might be clinically efficacious. There's you can talk to me in the chat later, or you can email me about a paper that's being discussed in Journal Club the day after tomorrow at Hopkins, where I will also be visiting virtually as a visiting prof, which means I get punished and have to give 3 talks, not just 1. But it's a very interesting paper that just came out in Cancer Discovery. So sorry about that. I think this is the last, or almost the last slide. So some of the ongoing and future questions I already told you about trials would include what I already told you about. And then the fact that we need to find ways to get patients who seem to need steroids for cerebral edema, a better way to get off steroids. And of course, one of them is obviously the use of these vascular endothelial growth factor inhibitors. But until we know better about those, we need to get the patient off steroids. And so if it does take starting with SRS rather than starting with systemic therapy, so be it. And that's probably one of the many reasons why starting with SRS is popular. So that's basically what it says in these 3 bullets. And then so the additional questions that have to be addressed are how to treat escape metastases, despite these really gratifying results with the currently available immune checkpoint blocking agents. We still see patients with escape metastases in the brain. For example, those who didn't have brain metastases to start with and who are in a nice remission with whatever they're in remission from extracranially, and then they develop a brain metastasis, but they're still controlled extracranially. I mean, we have SRS, but what else can you do to enhance the chance of their being controlled long-term in the brain? The diagnosis and treatment of radionecrosis, there are tricks that are played by the radiologist, and some of them claim to be able to distinguish radionecrosis from progressive tumor. And then the management of leptomeningeal disease for metastatic melanoma. It's very rare, but it's devastating when it does occur because it's almost completely untreatable. So stay tuned for the work of Bella Glitz and others who are working in this field. And so with that, I think this is the first time I've ever finished on time. Thank you for your very virtual attention. Of course, I'm happy to take any questions you may choose to fire at me. And my acknowledgement slide, not being a lab doc, is the groups that I've had the pleasure of working with, including Cytokine, the Society for the Immunotherapy of Cancer, and the faculties of the institutions I've worked at and those which I have not worked at. So there you are.
Thank you so much. What an elegant talk. And if anyone has any questions, please use the Q&A feature at the bottom of your screen. And I just want to let you know, while we're waiting on questions, that we will not have grand rounds next week. And we wish you guys all a very happy Thanksgiving. If you'd like to view any of our Winship Grand Rounds lecture, please visit the Grand Rounds page on the Winship Cancer Center website. So while we're waiting on questions to come in, I had a couple myself. One is, the biggest challenge is honestly, how do we look at this on clinical trials that exclude so many people with brain metastasis? I know we always push them to include them, especially now we do these screening, MRIs. We'll find a millimeter and it'll exclude them from every trial. How do we go about doing that? And have you had any success in trials that will allow tiny brain metastases for new drugs and new treatments?
Yeah, I mean, I like the last thing you said. It would be nice if we could say that, anybody with, I've never seen this actually, patients with up to 3 metastases, less than half a centimeter, let's say, could go on a trial without having had them treated. The vast majority, maybe I'll write such a trial, the vast majority of trials now allow brain metastases that have been treated, that are not recurrent, growing, requiring steroids, or symptomatic, and they require a particular interval. And so I have to credit, the people who write those studies. Some of them amazingly are pharma, and some of them are cooperative group studies. As I say, I haven't seen one that allowed really tiny brain metastases and required, intense surveillance, but that would be a good idea, I think. And maybe, and then of course there's the other piece, which is taking the new drugs into trials that are specifically for patients with brain metastases. So I have no doubt we'll be seeing, LAG-3 the 2 LAG-3 antibodies that I'm aware of. There's probably others, together with a PD-1 inhibitor, specifically for patients with brain metastases in a similar protocol design to what you've seen.
And have you seen with leptin meningial disease? I know MD Anderson's done a few trials. Do you think the biology is the same and it's just more extensive, or you think that the biology of leptin meningial disease is a completely different ballgame?
Yeah, you know what? I didn't put there was a there was a paper that I did not put any information from, sorry about the grammar, into this talk because I thought it would drag it out a little more and it would be a little esoteric. But the answer to that may come in part from Ina Smalley and Kiran Smalley and the group at the lab group at Moffitt, who's studying this, who recently published a very nice paper. I think it was also in Cancer Discovery or one of those other high impact journals, about leptomeningeal disease and studying, I think it was, if I recall, it was microRNAs went along with meningeal disease. And I'm not going to say favorable prognosis and unfavorable because it's all unfavorable, but they're trying to dissect this as we speak. And I think we're going to know some of the answers to that question before long, but I don't know right now. I mean, I think a different biology is the easiest thing to say, because who could prove that you're wrong, So
yeah, that's true. That's true. So we have a couple of questions in the chat. First off, from Dr. Waller. Why do you think PD-L1 expression on brain mets is of lesser significance in melanoma than other tumors? Do microglia upregulate PD-L1 in the setting of brain mets?
So the second question, I do not know the answer to. The first question, I will guess that among the reasons is that melanoma is much more immunoresponsive than many of the other tumors that are treated with immune checkpoint blockade. And that, I mean, this is going to sound kind of silly, but those tumors kind of need all the help they can get. And if their mechanisms for response to PD-1 or PD-L1 blockers is more of a dependence on what's called adaptive resistance, where you get a little bit of T cell activity, which then secretes TNF and gamma interferon, which turns on the PD-L1 on, let's say, the tumor. If that also turns on the PD-L1 expression on the local, macrophages and the astrocyte or the microglia, or the macrophages of the brain, then maybe it's that little bit of an accelerating immunologic process that doesn't need a lot of initial PD-L1 expression, but acquires it at a time when we don't see it because we don't biopsy those patients. That may be one of the reasons. That wasn't a very elegant explanation, but and it's only speculative, but that's the best I can do.
I know. Sometimes I think it's just that our response rate is so much higher that it has less variability, versus if you're starting out with a relatively low response rate, that PD-L1 status makes it significant.
Well, and there are examples of that. I mean, if you look at the diseases if you look at 067, we know that in the subsets that the patients that got both drugs, who got both drugs, it was that their response was less dependent on the expression of PD-L1 on tumor than was the case for patients who got nivolumab alone. And I think the same would probably be true for those diseases for which we're now treating with both CTLA-4 and PD-1 blockade, such as some cases of colon cancer, lung cancer, renal cancer. It may be that those patients have that their tumors are less dependent on PD-L1 expression on tumor. I don't know about in the stromal cells.
So I think one last question, and then we'll have to wrap up. This is from Dr. Shin. Radionecrosis versus residual disease. We all know, you mentioned it, is a super challenging issue. Do you have any biomarkers or anything in development that you know about liquid biopsies and melanoma? For us, I mean, sometimes they go to the OR and we find out what it is.
Oh, yeah.
But have you tried to use ctDNA or any other markers in this group?
I have not. I would imagine that there's all sorts of confounding factors, obviously the status of their extracranial disease. So I would defer this fully to the sort of the radiomics and imaging investigators who have their research and their tricks that they play. I don't know about them at this point.
Yeah, I think we need a lot of research there, because a lot of my patients go to the OR and ended up, well, maybe you didn't need that, no disease.
Yeah. And I think there are also, among the neurosurgical gurus, I know the Yale people were looking at methods for less invasive brain biopsies that don't require craniotomy. And I don't know, it's not my area of expertise, but that may be, get us there in a way that's not quite as devastating to the patients.
Well, again, thank you, everyone. I wish everyone a happy Thanksgiving next week. For those, we have a small group with women in Winship for those that want to join us after this. Take care.
Thank you so much.